My name is Ahmed Omar. I'm an orthopedic resident at Cairo University Hospital. This is my final year of residency, or more like my last 2 weeks. Uh, I'm currently rotating in Abu Rish Hospital, which is specialized in pediatric orthopedics. And I was asked to talk about Perthes disease and its controversies. So before I start, I'd like to talk about Abu Rish. So it's the pediatric division of the Cairo University Hospital. It's one of the biggest hospitals in the region and the biggest hospital in Egypt that's specialized in pediatrics. Usually we get maybe 500, 600 patients alone in the outpatient clinic in orthopedic pediatrics. We see all kinds of cases. The staff and the faculty there are really helpful, and they help us trainees a lot, and it was one of my favorite rotations. So I'd like to begin by thanking Dr. Teg for helping me during the making of this presentation. I'd also like to thank Dr. Higazi, who thought of this scientific event and requested this topic specifically, and Dr. Hassan Barbari, the head of the departments. So we're going to delve right into the topic. So if a patient, let's say 11 years old, presented to the clinic, they're complaining of hip pain. This is the X-ray. They're limping, and there's limited internal rotation. There's no signs of infection. So what could we think of? So we have to think of a differential diagnosis. It's usually going to be Perthes in such an age group. Usually it's from 4 to 8, but sometimes it can present a bit late. We also have to think, like we have to guess, is this patient in the outcome, is it going to be all right, like this hip, which is round spherical and there's no problems at all? Or is it going to be like this hip, which is flat? Or is it going to be like this hip, which is hinged? So there are lots of factors that we want to know to determine the prognosis. We also want to know what the management will be, when it should be done, and hopefully we'll know this by the end of this presentation. So we're going to begin with the introduction. This is like the points that we're going to try to cover in this presentation. First, we'll begin with the introduction. So what is Legg-Calvé-Perthes disease? Well, its history, it was first diagnosed independently by Waldenstrom in 1909 with the emergence of X-ray and its use in orthopedics. He wrongly associated it with tuberculosis. A year later, Legg-Calvé and Perthes both described the disease, and they described it independently, most likely due to a vascular cause. Waldenstrom later came in 1922, and he correctly placed the stages of the pathology. So the definition of Legg-Calvé-Perthes disease, it's a form of osteochondrosis or avascular necrosis of the femoral head epiphysis. It's usually due to an unknown cause that's thought to compromise blood supply. So if there's a really important point here, if we know the cause, then it's usually not Perthes disease. Like if we know it's due to trauma, avascular necrosis due to trauma, due to sickle disease, this won't be Perthes. Perthes is idiopathic. All right, so we're going to begin and talk about the anatomy of the physis to better understand the disease. So the femoral head in children, it's characterized by having a specific nucleus. There is bone in the middle here, and it's covered with cartilage, both articular cartilage and growth cartilage. So when we do an X-ray, usually what we see in young people, we see a specific nucleus. So we're going to talk about nutrition. The specific nucleus, it depends on direct blood supply for nutrition, while the cartilage around it, it depends on nutrition by diffusion. Hence, a vascular insult would affect the ossific nucleus while the cartilage won't be as affected. We're also going to talk about the blood supply of the femoral head epiphysis. So it's supplied by retinacular arteries. Also, there's transphyseal arteries that are present before 4 years. These are nutrient arteries that pass through the metaphysis and the physeal cartilage into the epiphysis. It's blocked at 4 years. So if there's osteomyelitis in the metaphysis before 4 years, it can develop into septic hip arthritis. And then there's medial epiphyseal arteries that come through the ligamentum teres. This usually appears after 7 years. So usually between 4 and 7 years, it's a relative ischemic state, and the femoral head epiphysis is supplied only by retinacular arteries. Right now, we're going to talk about the pathology. This is like probably the only parts of Perthes that's not controversial. So it begins with avascular necrosis of the femoral head epiphysis, and then there's the absorption stage, and then there's the replacement of new bone, and finally it's the end stage. So we're going to describe each stage independently. First, avascular necrosis. It usually lasts for 6 to 1 year. Usually avascular necrosis, it describes like necrosis is death of bone cells. So the bone is formed of bone cells and it's formed of matrix. So when there's a vascular insult, bone cells are affected while the matrix remains as it is. So these bone cells, the osteocytes and osteoblasts, they usually have pyknotic nucleus or absent nucleus, and hence there's no enchondral ossification. And hence the ossific cinder that we talked about, it becomes smaller, while the cartilaginous part that depends on diffusion keeps on getting bigger. So this is an animal model where they induced a vascular necrosis of one hip, and they took a picture, a pathological picture. Here we see the ossific nucleus is relatively smaller compared to the normal side, while the cartilage is increased in size relatively. And hence these cells, like they die by apoptosis, and inflammatory cytokines are increased. Interleukin-6 is released. This increases joint effusion, and it causes thickened peripheral cartilaginous cells, since their nutrition is by diffusion. And if we look at this X-ray here, the affected side, the right side, we can see that there is increased joint space. The reason for this increased joint space relative to the other side is that there is effusion, first and foremost, and then the increased size of the cartilage, like we described. So in the first stage, we usually don't see any changes in bone or the bone matrix, but usually we see increased joint space. We can see some signs of sclerosis of the ossific nucleus, usually due to calcified necrosis. And then the second stage, which is the fragmentation stage. So the dead bone is infested with vascular connective tissue and is actively resorbed by osteoclasts. This causes an epiphyseal height to decrease, which is due to collapse of the trabecular bone. And this is where the pillar classification depends on this stage. So this is an X-ray where the bone starts to fragment. And then the third stage, which is the regeneration stage, the fibrocartilaginous tissue begins to ossify, forming new woven bone. So how do we differentiate between the second stage, which is the absorption stage, and the third stage, which is the regeneration stage? Well, usually we can't really tell the difference. However, if we have a series of X-rays, once we see that bone starting to form, this is where the regeneration stage starts. So we can say that this is an absorption stage or a regeneration stage. It depends on previous X-rays, previous series X-rays. And then the end stage, where there's subchondral calcification occurs, last X-ray. We're going to quickly talk about the epidemiology of Perthes. So it occurs in males more than females. Is this a good thing or a bad thing? Can anyone suggest, why is it, would it be better in males or Would it be better in females, in the long-term outcome or prognosis? Well, usually it's better in males. Uh, the prognosis is much better in males because there is a longer age of remodeling in males. The second thing, it occurs in ages between 4 and 7 most commonly because, like we described earlier, it's due to the relatively ischemic blood supply. However, there's ranges that were reported between 2 years and 12 years. It happens usually in obese children. It also happens due to repeated microtrauma. It was found to have an increased incidence in children with ADHD. This could be due to microtrauma, due to their hyperactivity, or it could be due to them having ADHD. Lots of papers suggested that it has a positive family history. So if you talk to a patient with Perthes, usually the parents, some of them would say that they had a sort of hip pain when they were younger that wasn't diagnosed and they improved later on. However, there was a small study which was done on Perthes disease patients with identical twins. 10 patients were included in the study, and 0 out of 10 of the identical twins had it. So it's not really due to family history. It could be due to more like environmental factors. It's also higher in poor socioeconomic status. It was found to be higher in Asians, and a study done by Perry et al. Found that with each 10 degrees increase in latitude, it was associated with an incidence increase of almost 50%. So like when we go up above the equator, فوق خط الاستواء كل ما نطلع خطوط بالعرض, the incidence increases almost 50% for each 10 degrees in latitude. Also, bilaterality is almost 10 to 25%, and it's usually asymmetric. If it's symmetric, we have to think of other differential diagnoses. So I know like the epidemiology, there's lots of points that we have to remember. This was the study done by Perry et al. We collected epidemiological studies done around the globe, and he found out that with each 10 degrees increase in latitude, there was a 50% increase in the incidence of disease. This could be possibly due to decreased in vitamin D, or it could be due to the temperature. It's not really confirmed yet. And this is a graph showing it. So this is a picture that I drew through AI to remember the epidemiology. First, it occurs in children with 4 to 7 years of age. The child here is obese, so it occurs more in obese children, more in Asians. If you look in the background, it seems cold. So when we move away from the equator, the incidence increases. Also, there's other, like his family in the background. So it may have a positive family history or maybe not. It's still controversial, and it occurs more in poor socioeconomic status. So this is like a picture just to remember the causes. Right, so why don't we have better answers for Perthes disease? Why is it that there's controversies everywhere? Like when we think of the cause of Perthes disease, it's still controversial. No one knows the risk factors are controversial. We still don't know who exactly to treat, what stages. Like for every study that suggests something, there's another study that suggests something else. We don't know the best methods for treatment. It's still controversial. Every few years, new methods develop, and we want to know what is a good outcome to determine in Perthes disease. So some of the reasons is that there's very few pathological samples. So in Perthes disease, we try to preserve the hip, so we can't really collect pathological samples as much. We can't really study them. Something I'd like to point out, it's not due to the lack of research in Perthes disease. So Mercer Rang in 1993, he said shelves groan under the weight of literature on Perthes disease. So there's tons of literature out there on Perthes disease. However, it's usually done in single center studies, and there's a low incidence of cases, so they collect like very few cases. So for each study that says something, there's usually another study that says the opposite. So this is why there's still lots of controversies. All right, we're going to quickly talk about the classifications of Perthes. So to determine a good classification system, we define three categories. The first category, we define the pathological stage of the disease. Another classification would be to attempt to prognosticate the outcome. And then a third classification system would be to define the outcome. Also, all the classifications done for Perthes are based on radiological periods. So an X-ray is really important in Perthes. We can like only do an X-ray. So we usually do an AP view and frog lateral of any case. The classifications, there's historic classifications like the Legg-Calvé-Perthes classification. There's prognostic classifications like the Kitzaral, Salter-Thompson, the Herring. Then there's staging, Waldenstrom, and then it was modified by Elizabeth Town. And then there's classifications to determine the outcomes, such as Stolberg, Mohs, and CE angle. So we're going to begin with the historic classifications. First, the Legg classification, it described the outcome through the shape of the head. So it divided the outcomes into either a cap-shaped head or a mushroom-shaped head. And then Goff, he added the normal spherical head to the classification. Of course, this classification is not used anymore, so it's historic. And then there's classifications for staging. The most famous is the Waldenstrom classification. We described the first stage as necrosis, which we described earlier, and then the fragmentation stage. The third stage was bone deposition, and the fourth stage was remodeling. Another classification that was done, and it was done as a modification of the Stolberg of the Waldenstrom classification. It divided each stage into two stages. So the first stage, which is the AVN, it divided it into 1A, which is the epiphysis is avascular and appears dense. There's no loss of height of the epiphysis. And 1B, there's some loss of the epiphysis height. Okay. And then there's 2A, which is the fragmentation stage. 2A says that there's either one or two fissures that appear in the epiphysis, while 2B, there's multiple fissures that can cause maximal collapse. This is the stage of maximal collapse of the disease. And then in 3A, where there's bone deposition, there's new woven bone that begins to form at the periphery. And in 3B, lamellar bone starts to form. And then stage 4 is the healed stage. There are also some prognostic classifications. Kitzaral published it in 1971. It was the first widely accepted prognostic classification. It was based on the extent of involvement of the femoral head. He divided them into 4 groups. So the first group, he described it by affection of 25% of the femoral head. The second stage was 50%. The third stage was 75%. And the fourth stage was a whole head involved. So this was the first stage. Only 25% was affected. And it usually affected the interior part. And then the second stage was defined as an anterolateral affection of almost 50%. Also, metaphyseal affection was involved. The metaphyseal involvement was anterolateral. The third stage, over 75% of the epiphysis was involved. It also involved a posterior fracture that may have been associated with it. And in the fourth stage, 100% of the femoral head was involved. Kitzaral also in his paper, he put some risk signs for the femoral head. He said that there could be lateral epiphyseal calcification, lateral subluxation, Gage's sign, and the Café or Salter sign, which all had bad prognostic outcomes. This is lateral subluxation. And then the Gage's sign. This is a pathognomonic sign, which shows a small osteoporotic segment forming a translucent uh, V-shape through the lateral part of the epiphysis. So over here. And then the Salter or Café sign, which is a subchondral fracture that may occur in the anterolateral aspect of the femoral head epiphysis. Another prognostic classification was Salter-Thompson, which was described in 1984. He placed group 1 as a subchondral fracture involving less than 50% of the femoral zone. Usually it had a good prognostic outcome, while in group B, the subchondral fracture affected more than 50% of the femoral zone, and he described it as having bad prognostic outcome. And then the most commonly used is the Herring classification. This was based on radiographic changes in the fragmentation stage on AP view. We usually look at the femoral head pillars. We have a lateral pillar over here and a medial pillar. We look at the degree of collapse of the lateral pillar. We can either compare it with the normal side, or we can compare it with the lower medial pillar. So he put four stages or 4 grades. Herring A was normal lateral pillar. There was no loss of height, while Herring B was less than 50% loss in height, and Herring C was more than 50% loss in height. Later, another paper put a modification and stated or added another stage that was BC. And this had an average of about 50% loss in height. So in Herring A, we look at the lateral pillar. It looks normal. There's no loss of height. Usually it has a uniformly good outcome and there's no intervention required. In group B, there's less than 50% femoral or lateral pillar fall. It's good to intermediate outcome and intervention is warranted here. While in group C, more than 50% of the lateral pillar is collapsed. It shows poor outcome and it usually needs no treatments or no surgery.
Sorry يا أحمد for interruption.
تمام.
انت this is important في هنا الكومباريزون بتاع ال 50% دي بتكمبير بالنورمال سايد ولا the same side السنتر لللاترال؟
We compare the normal side to the other side.
Yeah, this is important. And I intend to يعني stress on this point. So as who gets it right. You have to see both sides in the same film.
تمام حضرتك.
Okay.
تمام.
Continue.
And this is an example of the Herring classification in an image. So A, there is no loss of height. In B, there is about less than 50%. In the BC, we can say it's almost 50%, while in C, it's there is more than 50% loss in height. Another classification that was used to measure the outcome was the Mohs classification. It measured the sphericity of the head. So he brought these circles, these concentric circles. So a concentric circle means that a circle, like several circles with a common center. And as we see here, just a second. So, for example, this is a circle over here, and then the circle below it, the difference between them is 2 millimeters. So how do we use it to measure the contour of the head? We place these concentric circles over the femoral head and the acetabulum, and we look at the sphericity of it. If the femoral head like has a flat part or a part of it is not continuous with the circle that we started with, we see the difference between how many circles there are between the femoral head. So let's say there is There's the femoral head here. I'm sorry, I'll just. So let's say this is the femoral head. This is the sphere of the femoral head. If we go over here, it's the same circle, okay? But if there was like a depression over here, it depends on the size of the depression. So depression could be either like this, or it could be like this. So here there's more than one circle difference, so it's more than 2 millimeters difference. While here it's almost like it's less than a circle difference, so it's less than 2 millimeters. So according to Mose, he said that if the congruity is good, if there's difference less than 1 millimeter, and it's fair if the difference is less than 2 millimeters. While it's poor if there is more than 2 millimeters in difference. Like we said, 2 millimeters is just the difference between each circle. Then one of the most famous classifications for measuring the outcome is the Stulberg classification. He placed 5 points. The first grade, he said that the shape of the femoral head is normal. It's spherical all through. At the second stage, there's a loss of head height, but it's less than 2 millimeter deviation of the concentric circles. So it's kind of like Mose. It's exactly like Mose. We just use his circles again. And then there's the elliptical head. There's more than 2 millimeters deviation of parts of the femoral head. And there's the fourth grade, which is flattened head. There's more than 1 centimeter of flattening. And last is the collapsed head. There's just a contour mismatch. Parts of the femoral head, it's not spherical anymore, so it doesn't go along with the concentric circles of Mohs. So for example, like femoral, I'll draw it. Femoral head's like this, and then it's just straight. It doesn't follow the sphere.
احمد ارجع بليز للدكتور هشام. دكتور هشام عباني،
ايوه حسن ايوه يا حجازي معاك.
انت يعني شيء يعني في ظهر اكتر من ستولبرج كلاسيفيكيشن تقريبا يعني.
في ايه؟
يعني في اكتر من ديسكريبشن لستولبرج كلاسيفيكيشن.
لا هو
يعني
الستولبرج
انا عارفه
كلاسيفيكيشن
ان
هو 5 جريدز.
5
جريدز
5 جريدز. اول اثنين سفيريكال.
one is spherical, second is spherical large, third
سفيريكال
نعم spherical
كده
large
اوفل،
second، وبعد كده oval، وبعد كده aspherical congruent، وبعد كده الفايف هي aspherical incongruent.
انا اللي انا قريتها ان نمره واحد سفيريكال with normal proximal femur، نمره
normal
اثنين
size.
سفيريكال ونمره اثنين سفيريكال بس في
large.
تشينج في الشيب اوف ذا فيمر، يا تشينج في يعني it is spherical بس larger، او it is spherical بس النك shorter، او في تروكانتريك اوفر جروس، او في كوكسافارا. يعني في تشينج في البروكسيمال فيمر بس الهيد سفيريكال. الثلاثه والثلاثه اوفل.
يس.
4 و5 incongruent.
نو
سوري
4
سوري
congruent but aspherical.
اسف. الاثنين اسفيريكال 4 و5، واحده with congruency، واحد incongruent.
بالظبط.
مختلف شويه عن
هو برضه كانت في البيبر بتاعت شتولبرج في 1981 he collectively made grade 1 and grade 2. كان عامل لهم classification ان هم good outcome with spherical head و 3 و 4 كانوا مع بعض، و fourth الثيرد class اللي هي كانت collapsed head. he also collectively
لا
like
هي المشكلة جاية من ال definition of what is flattening and what is elliptical. هو بيقول في الاوريجينال ديسكريبشن ده ان لما تلاقي straight area flat area 1 سنتيمتر ما تقدرش تشخصها انها elliptical or oval head.
تمام.
فلازم تقول عليها انها flattened head. الكلام ده متغير شويه ليه؟ لان الاوريجينال ديسكريبشن كان بيتكلم على الادلت ابييرنس. انت في البيدياتريك ما تقدرش تقول 1 سنتيمتر، دي مساحه كبيره جدا جدا.
تمام
وفي بيبر طلعت وقالت ان ممكن نفس الكلاسيفيكيشن اوف شتولبرج كلاسيفيكيشن ات ادلتس وات هيلد ستيج ممكن اقدر اصنف العيان according to شتولبرج. يعني مش لازم استنى للماتيوريتي بتاعته واستنى للادلت هود.
تمام
عشان كده احنا بنقدر نستعمله افتر هيلينج ستيج. بس ده بيعرفك، بس مجرد الفلاتننج ده بيعرفك يعني ايه الديفينيشن اوف فلاتننج، وما لخبطش بين فلات واوفال هيد.
تمام تمام.
طيب النقطة التانية يا أحمد، البروجنوزز في المجموعات دول بيبقى غالبا إيه؟ يعني هو بيدور على الشيب ده عشان الشيب بيترانزليت بعد كده.
بيترانزليت لأوستيوارثرايتس في اللونج ران.
بالظبط. ايرلي اوستيوارثرايتس وممكن ليت اوستيوارثرايتس.
كان في بيبر معمولة، كانت باي هيرنج، كان بعد 20 years من الكيسز اللي كان مجمعها. أول 2 جريدز لقى إن في تقريبا كانت 20% osteoarthritis، بينما في الثيرد والفورث كانوا 60 something، واللاست كانت almost completely osteoarthritis. في
ايوه،
اللونج ران
امتى الاوستيوارثرايتس؟
after 20
وين؟
years. كانت البيبر معمولة after 20 years من follow up.
بس انا متهيألي ان الحاجات اللي انا قريتها يعني الواحد واثنين الريزلتس بتاعتهم لحد ال 50s او their 50s او their 60s ما بيعوزوش ريبليسمنت، يعني زيهم زي النورمال بوبوليشن تقريبا.
تمام
المجموعه اللي بعديهم 25% بس اللي بيعوزوا في سن الخمسينات،
تمام
والمجموعه الاخيره دول بيعوزوا في سن العشرينات او كده. يعني هي دي اخر اتنين اللي هم الايريجولار هاتس.
تمام.
دول بيبقوا مشكلتهم بتظهر في العشرينات والثلاثينات والاربعينات.
ممكن اتكلم؟
ما انا اتفضل.
هي واحد
تمام. هو كان
آه، ممكن اتكلم بس
دكتور
كومنت.
هشام كان بيعلق.
هي 1 و 2 normal longevity of the hip.
تمام
3 and 4 زي بعض may be developed osteoarthritis at the age of 50s. 5 هو ده ال early development of osteoarthritis at 40s. والاوستيوارثرايتس الديفينيشن بتاعها مختلف، هي اللي هي clinically presenting ولا radiological appearance بس. البيبرز اللي بتتكلم على radiological appearance reported الاوستيوارثرايتس earlier than the clinically manifested osteoarthritis.
يعني ايه قصدك بكده؟ يعني
يعني
العيان
انت
بيبقى عنده
ممكن
باد اكس راي بس ما
يس
عندوش مانيفستيشن.
يس وده عادي ان the radiological appearance of osteoarthritis precedes the development of manifestation.
ماشي يعني اوكي، يعني احنا في الاخر بنتكلم ان تايب 5 دي
هو the worst.
20s او 30s كده بيبقى
Yes,
كريبلينج،
it is the worst. Yes.
واللي بعديهم بيجي 40s 50s. الاول
اللي هي
اتنين زي النورمال بوبوليشن.
بالظبط.
اوكي كمل يا احمد.
تمام. هو دي برضو كانت paper كانت by Larson. كان هو he followed up the cases that were done by Stolberg. Uh, he collectively classified group 1 and group 2. He found in radiologically the patients had osteoarthritis after هو كان عامل 20 years follow-up. يعني 22% of them had osteoarthritis. في group 3 لقى إن 61% had radiological osteoarthritis، وجروب 4 و 5 62%.
يعني it means that ان الثلاثه واربعه وخمسه زي بعض.
it's almost equal لبعض. وكمان معناها ان ممكن يبقى patient الاوتكم بتاعه شتوبر 1 او 2، يبقى outcomes كويسه ومبسوطين وبنطمن العيان ونلاقي ان هو suffered from osteoarthritis. So it's يعني ما بنبقاش ضامنين. We're not 100% sure of the prognosis or the outcome even if the x-rays are good.
طيب اتفضل.
ماشي. وفي another measure uh, angle of Weiberg بتبقى a line drawn from the center of the head اللي هو C والedge of the acetabulum E ودي وبنسميها CE angle. بيبقى في longitudinal end
لا
line in
بس
the center.
دلوقتي يا احمد
أيوه.
how to draw اللي هو اللاين من السنتر.
We determine the shape of the femoral head بنحط line
اول
exactly
بوينت اول بوينت كويس، دي
one point.
السنتر اوف ذا. وبعدين
وبعدين بنعمل longitudinal line
ما هو
upwards.
how will you do it؟
um, لا الصراحة مش متأكد. هو I know it's a vertical line with
يعني
X.
نروح كده، لا هاتها يمين شويه، هاتها شمال شويه، تعملها ازاي؟
آه، لا بنخليها straight يعني
ما
كأنها
هو ستريت على ايه؟
ما أعرفش الصراحة.
يعني لو
مبينة بالبيضة.
تخيلت ان السنتر اوف ذا هيب
مم.
دي بوينت كويس،
تمام
وناخد مثلا تراي راديت اللي هو الهيلجن راينر لاين
تمام
كويس، نطلع بحيث نبقى بيربنديكولار على اللاين ده.
تمام
اوكي.
تمام تمام
او لو ما عنديش خلاص العين اوسيفايد مثلا، خد اي تو بوينتس في البلفس وصلهم ببعض وخلي البوينت دي تبقى perpendicular عليه.
تمام
ده اللاين اللي بيقول لك ان انت كده aligned vertical على البلفس.
تمام تمام.
النقطة التانية
النقطة التانية بتبقى على ال edge of the acetabulum، على ال lateral edge of the acetabulum. و
بالظبط،
we draw a line
وصل
من السنتر لغاية اللاين ده. we measure the
لغاية
angle.
النقطة دي من البوينت اوف ذا سنتر لللاترال موست اوسيفايد بوينت في الاستابل.
تمام. وبعدين there's three classifications. If there's more than 20 degrees, it's a good outcome. If it's 15 to 19 degrees, it's fair. And if it's less than 15, it's poor. And it usually means there is a big parts of subluxation or deformity.
اللهم صل على النبي. اللهم هنا أنا العبد الفقير والعين الفقري.
Clinical picture. Uh, the symptoms, usually there's a limp exacerbated by activity and alleviated with rest. Pain which may be located to the groin. It can it can go to the knee or laterally.
بليز في نقطة هنا مهمة جدا.
تمام.
الليمب ده painful ولا painless؟ انت we classify limping as
Oh,
two
it's painful.
painful or painless.
Painful.
Sometimes it's painless.
تمام.
يعني كتير جدا الاهل بييجوا يشتكوا ان العيان ده بيعرج بس هو ما بيشتكيش،
تمام.
لدرجة ان some described it as a painless limb. Of course لو انت قابلت العيان وهو عنده ساينوفايتس هتبقى painful limb.
تمام.
يعني مش دايما بتبقى painful. Sometimes it's painless, sometimes it's painful.
حضرتك تبقى usually painful في الجريدز الأولانية ولا في الآخر
بالظبط
أكتر؟
كده. طبعا في البداية بتبقى painful.
تمام. وبعدين ممكن ال patient يدي possible history of several microtraumas. By examination, there is decreased range of motion of the hip, especially abduction or internal rotation. I'll explain this after we finish.
بس في نقطة برضو يا أحمد أحب أسألك فيها.
تمام
أنت قلت pain in the groin
تمام.
أو proximal thigh. Is this the usual
Uh,
in a child؟
in a child, هو
دايما
usually
الchild
بتبقى
منين؟ إيه
radiated
pain؟
to the knees أو في الهيد.
بالظبط كده. very frequently بتلاقي عيانين جايين عاملين اكس راي على الني.
تمام.
فدي بوينت بنحب نقولها للناس، دي لزمايلك يعني عموما لما يجي لكم حد please don't make the diagnosis increased ASOT وتعملوا اكس راي على الني. دايما لما طفل يشتكي من الني تجزامن الهيب لازم.
الهيد الأول. تمام.
ودايما لما الهيب بروبلم ممكن تكون باديه من السباين.
تمام
ودايما الريست بروبلم ممكن تكون باديه من القلبه.
تمام
ففي الاطفال احنا يهمنا الريجون اللي احنا بنكشف عليها، مش الريجون بس اللي بيشتكي منها العيان، كمان الريجون اللي هي فوقيها اللي ممكن تراديت ليها. اوكي كمل يا احمد.
تمام. متشكرين. وبيبقى فيه decreased range of motion especially internal rotation و abduction. Cause of this احنا قلنا ان في ال beginning of Perthes disease بيبقى فيه increased effusion most likely بيبقى بسبب ال necrosis of cells وال increased interleukin 6 و inflammatory cytokines which cause increased perfusion. The capsule is full of fluid where the most like most most the best position where the capsule can take as much fluids as possible بتبقى ال patient external rotation و mildly flexed and adducted. فبالتالي there's decreased range of motion on internal rotation because it increases the pressure in the capsule. Also, there's decreased range of motion. It's transient in the disease and it can be persistent later on, even once the patient is healed. Flexion and extension is less affected, so it's mostly internal rotation that's affected. We also have to think of the differential diagnosis. ممكن يبقى single.
قبل ما نسيب المنطقه دي يا احمد،
تمام.
هل في تايب اوف فيكسد ديفورميتي بيحصل؟
الفيكس deformity هي بتبقى mild degree of flexion و external rotation مع
excuse
مع
me
سنة
of
adduction.
ايه؟
نعم.
هو بيبقى في البوزيشن اوف ريست بتاع الجوينت غالبا بيبقى فليكشن ادكشن في الهيب، فممكن يبقى عندك فليكشن ديفورميتي اوف ذا هيب، يعني فليكشن ادكشن اوف ذا هيب.
هيبقى فيه
ودول
طبعا.
لو بقى لهم فتره كبيره بيبقوا فيكسد ديفورميتي. يعني اذا عملت توماس ساين هتلاقيها بوزيتيف على الناحيه الافكتد، هتلاقي فيه فليكشن ديفورميتي اوف ذا هيب، فيكسد فليكشن ديفورميتي اوف ذا هيب.
تمام.
اوكي.
We also have to exclude differential diagnosis once the patient complains of his hip. It could be a single side, and it could usually be tuberculosis hip, synovitis, slipped capsule femoral epiphysis, lymphoma, or eosinophilic granuloma. Or if both hips are affected, we usually think of multiple epiphyseal dysplasia, spondyloepiphyseal dysplasia, and sickle cell disease.
طيب ايه الفرق يا احمد؟ حاول تشرح لنا الفرق.
تمام. Usually في tuberculous hip, usually the patient, the signs are increased at night. He has signs of tuberculosis. There's night sweats, there's decrease in weight, and it usually happens in older patients. في synovitis, it's just transient, it comes and goes. ما بيبقاش فيه certain ما بتبقاش فيه X-ray affection أو حاجة ظاهرة على الإكس-راي. في ال
تمام.
slipped femoral capital epiphysis, usually there's an age difference in slipped capital femoral epiphysis. It occurs in older patients where we differentiate it by X-ray mostly. And lymphoma والeosinophilic granuloma بيبقى usually هتحصل في ال young patients. هتبقى يعني هتبقى الليمفوما هتبقى برضه في الافكشن بتاعت loss of weight, fever, في general signs or symptoms of cancer. Eosinophilic granuloma, the patient just complains of pain. That's constant. It's not decreasing. It's not increasing. And it's also differentiated by X-ray. There is a radiolucent circle in the femoral head.
اوكي.
For multiple epiphyseal dysplasia, it usually affects several long bones. You'll find it in both hips usually, and it can affect other long bones such as the tibia, the upper limb bones. It's usually just followed up. ما بنعملوش يعني ما بنعملوش treatment غير لو في أي deformities حصلت. برضه sickle cell disease the patient usually يعني بنحدده بنشوف الهيموجلوبين بتاعه hemoglobin electrophoresis و under microscopy بيبقى السيلز مع decreased oxygen tension it sickles usually the patient has a positive family history
Okay.
and he has other joints affected usually because sickle cell disease there is almost 1% of them that have a hip infection. Mostly they'll have something else or concomitant with something else, not just hip alone. Now we'll move to the investigations. So the most important thing is X-rays. Like we discussed earlier, all classifications depend on X-rays. Also, we determine the outcome by X-rays. So we, like in a case of Perthes, maybe we can only order X-rays and that's all. These are the stages that we talked about earlier. So in initial stage, there's a increase in the joint space. In the second stage, the fragmentation, and then the reossification, where compared to the fragmentation, bone starts to form again, woven bone usually, and then the heal stage where there's subchondral calcification. Okay, so there are other newer studies or other newer investigations, such as the MRI perfusion scan. So what is a perfusion MRI? حد يحب يتكلم عنها أو يقول هي إيه؟
لا كمل يا أحمد كمل.
تمام
كمل.
تمام. حضرتك هي البرفيوجن MRI ديت we do a regular MRI and then we give gadolinium or contrast and then we take another MRI after it, post contrast, in T1 images, and we subtract both images from each other. In parts where there is decreased vascularity, we usually find that it's hypointense, it's blackened. So what's the difference between regular MRI and perfusion MRI? Why would it help? So there are several studies that were done on this point. For example, this is an X-ray, a patient presented with Perthes. This is the X-ray that was done. An MRI was also done to determine the part that was affected. So looking at this X-ray, most suggested that maybe only 15–20% of the femoral head was affected. This is in a regular T1 MRI. However, in a perfusion MRI, we found that almost the entire femoral head was affected. And hence, lots of studies were done that found that subtraction MRI or perfusion MRI could actually help in determining the prognosis of the disease early on. So when a patient presents with stage 1, when in the first stage of bone necrosis or a vascular necrosis, we can determine what Stulberg classification he can become later on. All right, so MRI perfusion scan is not routinely used. Of course, contrast is expensive. It does have some mild side effects, such as allergic affection, renal affection. Also, some animal studies show that it's retained in the brain on the long run. This study was done by Hamrani in 2020 and found that gadolinium is retained in the brain. However, there was no found side effects. So it's still not known if it does have a side effect or not. Also, MRI perfusion scan can help to determine revascularization. So in the picture here, this was an initial MRI with MRI perfusion scan. Later on, in 5.7 months, we started to find that the lateral parts started to revascularize. Also, in the sagittal, the posterior part started to revascularize first. And then later on, the last part to revascularize was the anterior part. So they described that revascularization was in a horseshoe pattern. It starts in the posterior uh, parts of the femoral head, and then later the lateral and medial aspects, and finally the anterior aspects. This was also confirmed by bone scintigraphy. Another method that was developed is quantitative mapping of T2 MRIs. So this can also help us in determining the long-term outcome of Perthes disease, and we don't need gadolinium. That's the best part about it. So if we look at these pictures here, we like surgeons brought a pig and they took one of the femoral heads. They caused a vascular necrosis. They just did surgical dislocation. They cut the ligamentum teres. They tied around the femoral head, and then they relocated the femoral head and compared the normal side of the hip with the part that was operated upon. So they found that it showed that there was decreased vascularity, and it showed the parts that did have decreased vascularity. And this could be used instead of gadolinium for perfusion MRI with gadolinium. And the best thing about it is it doesn't need any contrast. It's just a system on the MRI, like on the MRI machine, and I added some of like how it's done over. So it just uses something called a spin lock radio frequency pulses. The only problem is that it's much slower than an MRI, a regular MRI. Right. So the management. First, we'll talk about conservative management. The primary means of treating symptoms related to Perthes disease was bed rest with or without traction. Mostly, this is a historic thing that was done, and we also say that local rest by non-weight bearing on the affected hip is suggested. A wheelchair, crutches, or a walker is prescribed, and short-term use of non-steroidal anti-inflammatory drugs for pain and discomfort may be used. Prolonged use of these drugs is best avoided, given that they may negatively affect the newborn formation. So in 2022, a study was done by Peck. He said that prolonged non-weight bearing treatment decreases femoral head deformity compared to symptomatic treatment. He advocated for non-weight bearing. Of course, the non-weight bearing was over 6 months. Most of the patients, the mean was at 12 months of non-weight bearing on the affected hip. However, this was a retrospective comparative study, and he included 11 patients. So it's sort of a weak study, or it's inconclusive. So the idea of conservative treatment is containment. So Harrison and Menon stated that if the femoral head is contained within the acetabular cup, it's kind of like jelly poured into a mold. The head should be the same shape as the cup when it's allowed to come out after reconstitution. So we say that if this case here, this patient here, he had a subluxation of the hip. So if he's left like this on the long term, the femoral head will reform. However, it won't be placed in the mold, so he'll have a deformed hip. So we have to return the femoral head or the femoral neck back into the molds so that it can form a spherical femoral head, kind of like jelly. So in 1922, according to this concept, Parker applied the earliest therapeutic application, which was broomstick plasters or Petri casts. He maintained the hip in approximately 45 degrees of abduction to help the femoral head remain contained in the acetabulum. Of course, the patient walks by crutches. He places crutches in the front and the back, and he walks sideways like a crab, kind of. Then other kinds of braces were done. This is the Atlanta brace. Patient here is also abducted. He can flex his knees normally. The Toronto brace, which helps the patient flex the hip and flex the knees. There's the Sneader sling. There's the A-frame brace. There's the Birmingham brace. There's the Newington brace. So there's tons of braces and suggestions for non-operative management in the form of braces. However, if we look at the two biggest studies that were done according to Perthes disease, the first was John A. Herring, which was done in 2004, and O. Wig, which was done in 2008. These are still the biggest studies that were done, or the biggest prospective studies that were done to include Perthes disease. What they found was that none of these protocols affect the treatment outcome, and Wig suggested that abduction orthosis should be abandoned in Perthes disease. So we don't use these orthoses anymore. Also, both papers suggested that if the patient is lower than 6 years, we usually just follow up. If the patient is 8 to 11 years, some patients benefited from containment surgery. It depends on the stage, the Herring stage. So they said that Herring B and C benefited from B and BC benefited from surgery. A and C did not benefit. And there's this controversial part where 6 to 7 years, Herring said that there's no difference in operation versus non-operation, while Wig said that there's better results in surgery. They both concluded that bracing has no benefits.
معلش يا أحمد، كومنت واحد بس.
تمام حضرتك.
الأوريجينال بيبر بتاعت جون أنتوني هيرينج هي الوحيدة اللي موضحها احنا بنتكلم على chronological age ولا على skeletal age. لو بنتكلم على skeletal age يبقى الكلام اللي بتقوله ده صح، اللي هو 6 years.
تمام.
لو بنتكلم على chronological age فبتزود سنتين على كل الكلام اللي انت قلته ده.
تمام.
وهم اللي موضحين الكلام ده فعلا، والعيانين دول بيبقى عندهم السكليتال ايج اقل من الكرونولوجيكال ايج. فعشان كده الانست اوف ذا ديزيز، ولازم توضح معنى كلمة onset of the disease، العيان بدأ يكومبلين امتى.
تمام.
فلو هنتكلم على chronological age يبقى هنتكلم على أقل من 8 سنين وأكتر من 8 سنين. لو هنتكلم على skeletal age يبقى أقل من 6 سنين وأكتر من 6 سنين.
يبقى عمليا نتكلم على
8 سنين.
ال8 سنين، يعني ال8 سنين هي ال6 سنين اللي انت كاتبها دي.
تمام.
والحقيقة الكلام ده متوضح وواضح very clear في الأوريجينال بيبر بتاعت توني هيرينج، ومش مكتوبة في الكتب. عشان كده دي فايدة إنك تجيب الأوريجينال بيبر وتقراها، فدي بتبقى فيها فرق جامد قوي، وهي اللي واضحة جدا 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 الحقيقة.
تمام.
بس في نقطة انت ذكرتهاش يا احمد هنا.
تمام.
هو هيرينج ما قالش ان هعمل اي تريتمنت. هو حدد عدد من السنترز، كل سنتر التزم بعلاج المريض بطريقة واحدة بس.
تمام. هو ما حددش فعلا.
ففي ناس كانت nothing، وفي ناس كانت فيزيوثيرابي، في ناس كانت بريسنج، وفي ناس كانت فيروس اوستيوتومي، وفي ناس كانت بتعمل سولتر اوستيوتومي. دول الفايف تايبس اللي هو درسهم.
تمام.
صح؟
لا مظبوط يا فندم.
هي الحقيقة توني هيرينج البيبر بتاعته كان الهدف بتاعها إنه يفاليديت his classification. فعايز يشوف ايه هي البريدكتورز for good outcome or bad outcome، والبريدكتورز for the final Stolberg classification للحالات اللي شافها كلها. ولما طلع البريدكتورز لقاهم الايج اوف اونست، لقاهم اللاترال بيلر، دول اهم حاجه، والرينج اوف موشن دي من الحاجات. لكن لقى حاجات تانية كتير قوي ملهاش اي لازمه وما اتغيرش. فهو الهدف بتاع البيبر مش انه يشوف نوع التريتمنت اكتر من هو يفاليديت الكلاسيفيكيشن بتاعه، ويأكد ان اللاترال بيلر ده has a significant effect in prediction of the final outcome.
بالظبط. يعني هو عايز يقول it's not treatment related، it is احنا لقينا العيان ده ازاي وقت الهيرنج كلاسيفيكيشن ما كان ابلايد. يعني الاونست اوف ذا ديزيز والهيرنج بتاعه كان كام في التوقيت اللي هو بدأ فيه الكلاسيفيكيشن بتاعه. بدليل ان هو يعني في اوقات كتيره قوي تريتمنت زي نو تريتمنت خالص، يعني تريتمنت يساوي نو تريتمنت. بس الليميتيشن ان هو هنا عمل 5 انواع فقط من العلاج، اللي هم 3 نون اوبراتيف و2 اوبراتيف. كمل بقى احمد.
في contrary to the previous papers، في paper اتنشرت كانت by Margaret في 2013. They said that during a 25-year follow-up, it was a retrospective study, including 213 patients that had Perthes. They were placed في A brace زي اللي في الصورة ديت. They found that 78% of pillar B and C were spherically congruent hips at maturity, overall كان 93% were congruent لو عملنا inclusion the pillar A. They suggested in A brace was effective. However, no other paper suggested this.
هو هنا قال انهم بيبقوا كونجرونت، ما حدش قال انهم يعني مش كونجرونت. يعني تلاقي انكونجرونت دي صعب. هي المشكله بقى الناس دي هتشتكي من الهيبس بتاعتها امتى وهتعوز ريبليسمنت امتى.
دي للاسف ما عملولهاش انكلوجن، ما ضافوهاش في بحثهم.
بالظبط كده.
دلوقتي هنتكلم على الاوبراتيف مانجمنت. So the keyword اللي احنا قلناها قبل كده هي containment for operative management. Usually to assess for containment before surgery, ممكن بنعمل arthrogram عشان نشوف if the hip can be returned back. Usually we do 3 types of operations. ممكن femoral osteotomy اللي هي proximal femoral varus osteotomy. ممكن نعمل pelvic osteotomies، ممكن نعمل shelf osteotomy، أو ممكن نعمل arthrodiastasis. ففكرة femoral osteotomy, usually there's part of the femoral head that's subluxated or it's not covered. Like we said, we want to attain full coverage of the femoral head so that when there is remodeling, it can be normal again. So we do a varus osteotomy. Example, hit this yellow part that's outside the hip, it returns back. So in that it molds again, it forms a femoral head that's spherical. هل femoral varus osteotomy, its idea is just covering the femoral head? There are several studies that were done. They suggested that it also helped in bypassing fragmentation. So in cases where the fragmentation part was quick or it was short, it was found that they had a better outcome in the long run. There were several studies. The last 2 were done almost 3 years ago. This is an X-ray of a case that was done. They suggested that we do the femoral varus osteotomy early in stage 1. We determine like the outcome of it, usually by perfusion MRI. We can use other quantitative MRI methods like we mentioned before. If it's going to be progressive, we usually do a proximal femoral osteotomy in stage 1 of Perthes disease. And they found that fragmentation stage was bypassed. So these are some cases. As we see here, this was Perthes 1. They did a femoral osteotomy and the patient didn't pass through fragmentation. Also, I think that this would include several studies later on, and it could affect the management. Other operative managements, Salter, like we can do pelvic osteotomies, such as Salter's osteotomy. It's usually done in combination with femoral varus osteotomy. Also, there's shelf acetabulouplasty. There's a study that's being done currently in Abu Rish by Morsi, where he compares femoral varus osteotomy with shelf acetabulouplasty. However, he suggests that femoral varus could be better because there's a shorter operative time and better recovery times. and there's less post-operative complications with similar Stolberg outcomes. Another thing that is done is arthrodiastasis. It also helps in the containment later on. Another type of operation that we can do after healing is valgus femoral osteotomy, only if the patient has a hinge abduction. So once the patient heals, he can complain of pain, especially on abduction. This is an arthrogram. This is the hip in neutral position. As we see, there is no problem. However, once the patient starts to abduct, there is a hinging over here on the lateral side of the femoral head. So in these cases, we can do a valgus osteotomy so that the femoral head is contained better and there is no hinge abduction. Some papers have suggested medical management for Perthes disease. So some suggested bisphosphonates. They describe that there's a race in Perthes disease between resorption and formation. So in normal bone formation is equal to bone resorption. However, in Perthes, especially in the second stage, where there's excessive bone resorption, while there's decreased bone formation. So this helped more in femoral head deformities. A paper done by Megan Young collected several studies. Out of 8 experimental studies reviewed, they found that 7 reported reduced femoral head deformity and 6 found better preservation of trabecular framework. The papers were done in animals and were not done on people. So maybe later on, studies can be done, like clinical studies can be done, and they can determine if bisphosphonates really are effective. Some other papers suggested that there's a downregulation of microRNA in Perthes disease. So they said that microRNA 214 is one of the causes that causes problems in the ossific nucleus of the femoral head because of this downregulation. And they said that if a drug is made to target this downregulation and increase its formation of microRNA 214, it can be helpful in Legg-Calvé-Perthes disease. However, this is just a hypothesis. Also, another paper suggested giving bone morphogenic protein 2. So they gave it in cases in porcine models or like pig models where they induced avascular necrosis, and then they gave BMP2. They found that it minimizes femoral head deformity and it speeds up bone formation. So it's kind of the same idea as bisphosphonates. Also, some other papers talked about if Perthes disease is actually due to an inflammation problem. A study done in 2015 said that children have prolonged synovitis on MRI and elevated synovial interleukin-6, which they suggested could be one of the causes. Or if we control this, then the advancement of disease can be contained. Another paper done in 2018, it said that interleukin-6 knockout mice have improved revascularization and new bone formation, so that the mice can't produce interleukin-6, and hence they had better revascularization compared to other normal mice. And another paper done in 2020 said that anti-interleukin-6 therapy decreased hip synovitis, osteoplastic bone resorption, which is one of the major problems in the fragmentation stage of Perthes disease, and increased bone formation in piglets. So we're going to go to the conclusion. Of course, there's lots of stumbling blocks that we have to identify in Perthes disease. There's lots of problems. So basically, the etiology is unknown. The only thing that's maybe clear in Perthes is at the pathological stages. We also have to consider other differential diagnoses. Treatment is controversial and needs more studying. Like we said, nothing is 100% like confirmed. And even if a paper says something, usually there's another paper that says the opposite. Assessment of outcome is controversial, even in Stolberg patients, and they may suffer from osteoarthritis later on in life. Like we said, that the first two stages, they can have osteoarthritis radiologically. in almost over 20%. Thank you.
Thank you, Ahmed. It's time for what went well in this discussion. ايه رأيك يا دكتور هشام في البرزنتيشن دي؟
شكرا يا حجازي. شكرا يا احمد.
What went well في البرزنتيشن؟
الحقيقه اللغه كويسه، البرزنتيشن كويس، لكن البرزنتيشن هو اتظلم فيه. ليه اتظلم فيه؟ اتمنى ان بعد كده يبقى التوبكس اللي ياخده البريزنتر يبقى لوكالايزد ومحدد جدا ويتناسب مع وقت معين محدد. احنا ممكن نعمل كورس يومين على بيرثز ديزيز ونقعد نتكلم يومين على بيرثز ديزيز بس. اوكي، فانا من الظلم اني اقول لحد اتكلم على البيرثز ديزيز كله في برزنتيشن نص ساعه او ثلث ساعه او حتى ساعه. اوكي،
ايوه
فهو اتظلم في كده. مثلا هندي حد توبيك نقول له كلمني على الكلاسيفيكيشنز، فيبدا يدور على ما هو جديد وبتاع وناخد معلومه ونطلع بمعلومه مفيده. جزء كبير جدا من الكلام ابيديميولوجي وبتاع اي حد ممكن يقراه، لكن انا مثلا ما شفتش ميتا اناليسيس للتريتمنت مانجمنت عشان نشوف الافشنسي ولا مين احسن من مين. ماشي، هو ده اللي احنا عايزين نسمعه، لان كلنا بنشتغل بدياتريك اورثوبيدكس، كلنا ناس بنقرا في البيرثز ديزيز، كلنا ناس عارفين الباثولوجي وعارفين الكلاسيفيكيشن. انا ما يهمنيش